And it's now a pleasure for me to announce Brochard giving a talk on the general principle of non-invasive ventilation. And I have the huge advantage that we are gaining time because I think I don't have to introduce him really. So please, Laurent, go ahead.
Thank you, Michael. Thank you very much. The general principle, as I'm sure you all know, for non-invasive ventilation is to avoid the need for endotracheal intubation, which is the classical way to have access to the lower airway in the intensive care unit. Therefore, non-invasive ventilation should be applied at a time where the patient does not yet need the ventilator, so before. For instance, we may decide if Marco Ranieri's condition worsen, whether he needs now non-invasive ventilation before being intubated tonight. This is not Marco. Huh? So the principle is that it's a mixture between a ventilatory support like the one you deliver in intubated patient and a preventive tool to avoid further deterioration and a need for immediate intubation. I think this is very well illustrated in this set of physiological data obtained in patients with COPD and acute exacerbation. You have here a number of physiological variables, the respiratory rate, the tidal volume, the minute ventilation, and the pressure generated by the diaphragm of these patients at each breath. The first condition is a control condition, and you have here an example of one patient with the different tracings. We know that these patients are breathing with high respiratory rate, low tidal volume, and high transdiaphragmatic pressure. And this is especially important to keep in mind. This level of pressure generated by the diaphragm at each breath is extremely high. You or I, maybe not Marco because he is sick, but we probably generate something like a few centimeters of water of pressure to get much higher tidal volume. So the transformation of this pressure into volume at the mouth is very poor because of the poor respiratory mechanics of this patient. So as a consequence, they try to poorly compensate by increasing respiratory rate, but because of the dead space to tidal volume ratio, they progressively worsen their respiratory acidosis. And therefore, you need to have something to stop this vicious circle, which will lead to either respiratory arrest or need for immediate endotracheal intubation. And this is what can be offered by non-invasive ventilation. By using a mode which synchronizes reasonably well with the patient, you can increase the tidal volume of the patient, in response to which the patient is going to decrease his inspiratory effort, and you see the significant decrease in transdiaphragmatic pressure, which is illustrated here by the decrease in diaphragm EMG. As a consequence, the patient can decrease his respiratory rate and improve the condition. And you can do that intermittently while the medications you have given will improve the patient. As already alluded to by our chairman, the major issue there is that the interface is different than during conventional mechanical ventilation. You know that you can use a nasal mask, nasal pillows, or facial mask. In the ICU, in most of the case, we use those facial masks covering both the mouth and the nose for many reasons, including the fact that many patients are mouth breathers, and it will be very difficult to ventilate them only with the nose. So there are many different interfaces, many different sizes, and also new type of interface covering the whole face, which is an attractive option to vary, for instance, the distribution of pressure of the mask, not only always on the nose, but also on the whole face. This issue of the mask fitting to the patient's face is specific to non-invasive ventilation and is crucial. It was very interestingly studied by this study from Brazil, published in Intensive Care medicine looking at the mask mechanics and the leaks dynamics during non-invasive ventilation in a bench study. They studied that they measured at the same time the pressure in the mask, so the airway pressure for the patient, and the pressure within the cuff, the cushion of the mask. When the pressure in the cuff remained higher than the pressure delivered by the ventilator, there was no leaks. And you see here the delta between these two pressures, which never goes below zero. So in this situation, pressure support was delivered adequately with no leaks. But when the pressure in the ventilator became higher than the pressure within the cuff, then the delta pressure crossed the zero line, and there were leaks and this usual asynchrony, which is a prolonged inspiration because the ventilator becomes unable to detect the end of inspiration. So this is a key issue in the specific aspect of non-invasive ventilation. The other key issue is the comfort of the patient and the tolerance of the mask. And this kind of study, like the one by Gregoretti and published also in intensive care, looking at the tolerance of new masks is probably something important. They showed here that compared to another more classical mask, this one having different pressure distribution again on the face was better tolerated. And as said by Nick Hill in his editorial, this will save faces and also increase the success of non-invasive ventilation. The last type of interface, the very attractive one which has been discussed in depth at this meeting, is the helmet described by the group of Antonelli and co-workers, and which may be a tool markedly improving the tolerance of this type of ventilation. And we'll see in the future whether the improvement of tolerance will balance the negative effects on the quality of ventilation and what is the most important for the success of NIV. Therefore, I think that in the ICU, if you use non-invasive ventilation, it may be important to be able to vary the type of interface. For instance, in our ICU, we use this classical face mask. In a very few patients, we sometimes use an oral interface for instance, these patients with chronic emphysema, totally mouth breather, who could do well for a short period of time with this mouthpiece. But also we have new type of total integral interface, which clearly allow not only to increase tolerance, but also to vary the type of mask and to vary the pressure on the face of the patient. The leaks and the asynchrony generated by these leaks on the ventilator are again key issue for the success. Last year it was presented at this meeting a study performed by François Lelouch from our group, comparing, for instance, the different types of interface and the results in terms of work of breathing, leaks, and asynchrony. And I'm not going to show you all the details, but just to show the amount of leaks that we measure with the different interface, which with the integral face mask, the first facial mask, the second facial mask, and the oral interface. You see that leaks, despite very careful conditions, were around 30%, which means that 30% of the inspired volume was only leaks going out and not to the patient. You see also that the amount of asynchrony measured every 5 minutes was quite substantial, and clearly the oral interface was less efficient than the other and increased leaks and asynchronies. The next issue is how often now do we use non-invasive ventilation? And we don't have a lot of data. This was an international survey of mechanical ventilation all over the world conducted by Andres Esteban and published in the JAMA. In this study, if you look only at the rate of use of NIV among the 28 days of the study, and here you have the number of patients every day. You see almost 5,000 patients. You see that NIV is close to 5% of the modes of mechanical ventilation. So it seems to be a low number. However, this survey was first performed in 1998, and second was only looking at patient ventilator for more than 12 hours. So it may well be that many patients ventilated only intermittently a few hours per day with NIV were missed by this study. We have performed 2 repetitive studies in France, and I'm briefly going to show you the second one, which was presented at this meeting by Alexandre Demoule from our group. In March 2002, we looked during 3 weeks at all patients admitted in 70 ICUs. During this period, almost 2,000 patients were admitted, and approximately 55% of them were under any kind of ventilatory support, either NIV or standard mechanical ventilation. When we look at the distribution of these patients, approximately 40% were ventilated in the ICU, whereas 60% had been already ventilated before admitted to the ICU. Of course, in this group, very few patients were ventilated with NIV, but also already a few patients were ventilated by the emergency service with NIV. In the group ventilated in the ICU, you see that a large number was ventilated with non-invasive ventilation. And the total was that 24% of patients were ventilated with NIV as first-line treatment, which means that 1 every other 3 patients is ventilated with this technique. It's a huge number. And the most striking result is the comparison with our previous study in 1997. In 1997, the use of NIV was 16%. In 2002, it's now 24%, which is a very significant increase. But probably more striking is the use of NIV for patients admitted in the ICU, non-intubated. So these are really the patients for whom the physician has a choice between the tube or the face mask. And in 1997, it was 35%. In 2002, it became the #1 approach to ventilate patients admitted with respiratory failure in these 70 French ICUs. So this is a huge increase, which is interesting to note because there are not so many medical progresses which are accepted so widely and so rapidly by physicians. And if we look at the different categories of patients, you see that, of course, in green you have patients requiring intubation. In red, patients ventilated with NIV. In the group with coma, no patient was ventilated with NIV, which makes sense because there is no protection of upper airway. It was used in 2/3 of patients with hypercapnic respiratory failure, used in approximately more than something like 25% in hypoxemic respiratory failure, and close to 50% in pulmonary edema. The last point I'd like to address is now when should we use NIV in an individual patient, and when is the risk of failure high or low? I think thinking in individual patients why and when to use NIV, there are 2 important aspects. The first one is the aspect of risk versus benefits. And the risk of NIV are those associated with late NIV failure and late need for intubation. In those patients, you may think that you lose some time because it could have been better to intubate this patient earlier on. The risk of mechanical ventilation are well known, and we all know that it's especially important in some patients at very high risk. I just take the case of patients with immunosuppression. We know that they are at extremely high risk of infectious complications if they go to mechanical ventilation, sedation in the ICU. Therefore, the balance may well be towards the NIV arm, because you really want to decrease the risk associated with mechanical ventilation. The second issue is the expected duration of the underlying disease. Let's look at this schema of the clinical course of a patient. This patient may have respiratory failure, and you may start non-invasive ventilation here. So instead of going for endotracheal intubation here, you may just delay the need for endotracheal intubation, because the patient's condition is so severe that it will take weeks to recover. This is the case, for instance, of many severe community-acquired pneumonia or ARDS. By contrast, if the process is reversible in a few days or is transient, you have much more chance to be able to take the patient out of this zone where he will need intubation. And I think all patients with COPD, with cardiogenic pulmonary edema, many with lung contusion will fall into this category. So I think these two principles are very important for the individual decision. Thank you very much for your attention.
Thank you, Laurent. We have time for one or two short questions. There is anybody? Please.
You told us that there have been more than 50%. That there have been more than 50% of your patients admitted to the ICU have been under non-invasive ventilation before admission. That means that they have been started with the non-invasive ventilation in the bedroom of the patient, say with a pulmonary edema or something like that. So how did the patients accept this non-invasive ventilation at the scene?
I'm not sure I understood the beginning of your question.
You told us that 52% of your patients admitted to the ICU have been already under non-invasive ventilation when they came to the hospital.
No, I'm sorry. I meant that for patients admitted in the ICU free of intubation, because many patients are transferred to the ICU already intubated. If we look just at those who are not intubated when coming to the ICU, I say that for 52% of the case where any kind of ventilation is applied, it's non-invasive ventilation. That's what I mean. So it started in the ICU.
Okay, I understood. Thank you.
Sorry for the confusion.
Very, very short question. Laurent, how much important is patient-ventilator desynchrony to success in non-invasive mechanical ventilation?
We don't know. So that could be a short answer. This is a major topic to study. I'm quite sure that one of the big risks of non-invasive ventilation is that you may have a total desynchrony between patient and ventilator, and still the ventilator looks okay, but the patient will not be correctly ventilated, will worsen. That's why I really favor to have a very good monitoring in those patients, and I think it's really not a simple task to do non-invasive ventilation.
One short question for me. You said that we didn't do any tremendous advance over the last 5-6 years, neither in understanding, neither in interface, okay, some. So how do you explain this absolute impressive increase in non-invasive ventilation?
I think it's a very interesting and exciting question. Why some progress in medicine take years or decades to go into clinical practice, and why this was so widely accepted. Probably in part because first you see immediately the effect, which is obvious. Second, maybe because all intensivists know that intubation is a risky job, and therefore being able to avoid this, I think, is very easy to accept. But it's an interesting philosophical question, I think.